and then a spine fellowship. Before that, he went to Samford, I noticed, as well. So we look forward. He's going to give us, I think, an update, sort of an overview of neurosurgery and some of the new things that are going on in that world today. We appreciate you being here and look forward to your talk.
Thank you for having me. I've met most of you, and I appreciate you having me. I'm Jody Miller, and I appreciate the introduction. And feel free at any moment to interrupt and ask questions, raise hands. I'd like this to be as interactive as possible. So I want to keep our goals fairly simple. My grandfather, he had this rule of threes, and he educated Peter Boehm Sr. and most of my partners here. And he basically said throughout his career that no one, not even the smartest neurosurgery resident, can remember more than three things from a lecture. And where he took that from is there was a Princeton psychologist, George Miller, in 1956 that basically said that people can't remember more than about 7 things from a talk. So we'll try to keep things simple, and hidden in here are 7 lucky pearls, so we'll see if we can find them. But first things first, being a neurosurgery talk, we got to get this out of the way. So this is interesting. So I'm sure most of you have heard this podcast. This gentleman, he was a collegiate football player, and this is when I met him, and he was at Memphis. And so I interviewed there for residency. That's where my grandfather trained. That's where I was interested. And many of you in this room, I see, you spent time there. And you meet this guy. He's sharp. He's a PhD. He takes you to his lab. He's interested in stem cell research. And then how do you turn into this guy? This is what you want to avoid. And this is the first pearl. Drugs are bad, even for surgeons. And so that's the unfortunate thing about this Dr. Death story, is that you have a bright individual who did not have much surgical talent, who avoided the operating room, who avoided doing cases, and his life spiraled out of control. And, the heroes of this story were, the vascular surgeons, who kind of stopped this whole thing. And so as, residents in your training, these things happen. We see patients who are physicians who are impaired. There's neurosurgeons in the state of Alabama who've been to rehab 3 or 4 times. And there are residents who avoid doing operations. There are residents who leave early, who herald the work hours of getting out of work. But the most important thing and the most important takeaway for me is to become a great surgeon, you have to do a lot of cases. You have to be competent. You have to learn from your attending mentors. And you have to put in everything so you can get out everything. And he didn't put in anything. He put in no effort. He avoided the operating room, and his life spiraled out of control. And now, unfortunately, he's blemished the name of neurosurgery. And that gets us to the next thing. So the main purpose of my talk is to take home some pearls of how to evaluate the neurosurgical patient. So this is great for our medical students and junior residents. And my very first lecture in medical school, first day, first lecture, I'm wearing a tie, I'm sitting on the 3rd row, I'm excited. And I have a general surgeon get up and present a series of cases. And these were disasters. There was situs inversus where the x-ray tech had flipped the image and they didn't look for the marker at the top of the screen to check the side. He does an operation on the wrong side of this child's chest. It was case after case. And that very first lecture in medical school stuck with me. Trust no one and expect sabotage. My dad said the same thing. When he was a resident, they would be fired on the spot if they didn't look at the images themselves. My grandfather said the same thing. So always look at your own imaging, especially when you're on trauma and you're responsible for the entire patient, because it's really not that difficult. And so for me, the most important thing when you're looking at spine imaging is to start with the sagittal, because the sagittal, it's a cross-section view looking from the side of the patient, and that defines the spinal canal. The spinal canal is where the spinal cord is, and it's made up by 2 lines. It's made up by the posterior vertebral body line and the interlaminar line. So if you have an intact posterior vertebral body line and you have an intact interlaminar line, the spinal canal, from a bony standpoint, is largely intact. And that's the first place to start. And this is a great illustration of disruption of your posterior vertebral body line and interlaminar line. And that's not good. So this is exactly the same image, but of the cervical spine. This is your mid-sagittal image. This is a great place to start. And this is your posterior vertebral body line and your interlaminar line. And then we go over to the facet joints. We scroll out laterally. We look at our facet joints, and the facet joints are these structures here, and they're supposed to shingle over one another like the shingles on a roof. And instantly your eyes come to this, and after you've looked at thousands of images, you can't help but your eyes jump right to the problem. So we see that we have an injury to this facet joint. This is the 5-6 facet joint. So then, to confirm this, we scroll down through our axials, and we're like, okay, what's going on with this facet joint? So this is the lateral mass here. And if you kind of imagine this as being like the pillars of a house that hold the structure of the cervical spine up, that's why this is called the articular pillar. And if you disconnect the articular pillar by fracturing through the lamina and the pedicle, this is an unstable fracture, because basically you've taken half of the most important joint of the spine out of the structural support of the cervical spine, and these are unstable fractures. So again, the radiologist read this as a transverse foramen fracture with a small laminar fracture. So if you would have read the report, you would have brushed it off, maybe gotten a CT angiogram of the head or a CT angiogram of the neck to make sure there was not a vertebral artery injury, but you may not have realized that this is actually an unstable fracture that does need a spine surgeon to evaluate. And then I go to the coronal images. The only time I ever look at the coronal images in trauma is at the craniocervical junction. I look at the occipital condyles, the C1 lateral masses, the odontoid, and C2. Looking through the rest of the coronal imaging, it's important in the abdomen, it's important in degenerative spinal conditions, but it's not important in the rest of the spine. So to kind of keep things simple and on schedule, let's talk a little bit about cranial imaging. So cranial imaging, you kind of get lost in neuroanatomy. We all remember learning all these fiber tracts and locations of the brain, and it's overwhelming. But I encourage you in the trauma bay to keep things very simple. So the skull has a hole in the bottom of it that your patients are trying to push their brain down through that hole if they have high pressure. So if that's where it's all trying to go, we should start down there and look at the hole first. And that's called the foramen magnum. So if you can discern structures in the foramen magnum, if you can see spinal fluid around the cervicomedullary junction, if you can see the tonsils, if you can define anatomy and it's not all gray, there's probably not a major problem in your patient that's received, ketamine and VEC and all these other things in the field that you just can't evaluate. So I always start at the hole at the bottom of the skull, and then that's a water space. That's where CSF is. And then I go up through the other water-filled spaces of the brain, because that is what the brain obliterates when you're herniating. So I look at the cisterns and the ventricles. So I look for patients who have uncal herniation. So I look in this area here around the midbrain and brainstem. You can learn the names of all the cisterns if you would like, but what you really need to learn is that there are cisterns and what they look like. You don't need to know that there's the ambient cistern and the quadrigeminal cistern and the prepontine cistern. That's too much information. What you really need to look at and understand is the basic concept of cisternal anatomy in the brain and what that means for your herniating patient in the TICU when you order that stat head CT in the middle of the night. Because water's life. Water is this precious resource, and that's the most important thing in the brain. It's water, and it's the water-filled spaces. And then I go up to the ventricles, which are these fluid-filled spaces where most spinal fluid is produced. And then after that, then we kind of scroll through and we look at the parenchyma. We look at our gray-white differentiation. We look at the posterior limbs of the internal capsule, the thalamus, the caudate. We get lost in looking at all these other things that are still important. But really, if you look at the foramen magnum and the cisterns, you'll identify most problems. And then we look at the convexity for our subdural and epidural hematomas. Then we look at our bone windows. But I don't want you to get caught up in the details. Keep things simple. And that's how you keep things relatively safe when you are having a complete overload of information in the middle of the night when you have 32 CTs to look at, one of which is a head CT. So let's take a little detour here. This is me. This is a CT scan intraoperatively. This is putting in navigated pedicle screws. So CT scans emit radiation. So this is my pearl number 3. This is one thing I was never taught in residency. So I stood next to a fluoro machine for 7 years. The x-ray techs would stand on that little plus button because they didn't want the evil neurosurgeon to yell at them and give them a great image. And what I've come to realize is that the average neurosurgeon, the average urologist, the orthopedic surgeon, those of us and you who put in central lines and do interventional procedures in the vascular lab, most of us hit our lifetime radiation dose in the first 10 years of our practice. And so radiation's bad. It can cause cancer. It can cause cataracts. There's stoichiometric risk, like you will develop cataracts if you get exposed to enough radiation. You may develop cancer. So the details of this are interesting. So what I try to teach is that we need to use as low as reasonably achievable dose. We need to stand as far away from the fluoroscopy machine. We need to learn how to run the GE fluoro machines better than the techs, because most of the techs here do not know how to run that machine to decrease the radiation exposure to the surgeon and to increase the image quality. So I definitely want all of you who work with fluoroscopy in the operating room to learn about the pulse button, the low dose button. How do you turn down the pulse rate? How do you get good images while decreasing the radiation exposure to yourself? That's important for maybe the vascular surgeon, the urologist, but it's important for all of us. And so that's my aside for radiation safety. So now back to some more radiation. So this is getting into the thoracolumbar spine. So the thoracolumbar spine, it's the same principle. It is our posterior vertebral body line. It's our interlaminar line. It's our vertebral bodies and pedicles. It's our facet joints articulating with one another. The transverse processes are not important. What is important is figuring out, okay, I have a patient here who has a fracture. They're neurologically intact, and it appears that their ligaments on the MRI that we all love to order are also intact. Does that person need surgery? Most likely not. And that's what all these different grading scales that you see that we put in our notes, the TLIX scores, they basically put a number on common sense. That's what people love doing. That's how academics publish. They put numbers on common sense decisions and then force it on us to use these scales. So if a patient has a clinically significant fracture with disruption of the ligaments and they have a neurological deficit, well, it goes to reason that they'll need surgery. But there are all these grading scales that we can kind of get lost in the weeds on. So now our CT scans are done. We've assigned our rating scales. We've looked at the cisterns. Now what? All right, so you examine the patient. You evoke some type of painful stimuli, which our nurses love using this particular method, which I don't necessarily appreciate. If any of you have children, I encourage you to experiment on the best way to wake someone up from a dead sleep. I found the most effective method, both in getting my 9-year-old out of bed to go to school in the morning and waking my patients up, is a good firm squeeze of the trapezius. It's incredibly painful. It'll take a 9-year-old to their knees, and it wakes up almost all of our patients. I'm kidding, of course, but not really. So we have a painful stimuli. We get no response. Now what? Houston, we've got a problem. And we've all had these discussions. Dr. Miller, the patient is over the age of 55. They have a GCS of less than 8. What do we need to do? Do you want me to put a bolt in? Okay, well, let's think about this. Let's think about what the goal of a bolt is and what our goals are of taking care of this patient. The goal with the brain is to get blood to it. And so the blood, remember the hole at the bottom of the skull? The brain is in a fixed container, and we have to shove blood up through these holes in the base of the skull to get blood into the brain. That's basically the premise behind cerebral perfusion pressure. So basically, your mean arterial blood pressure has got to be high enough to overcome the intracranial pressure. That's why we would want a bolt, to figure out what is going on inside this bony vault of the skull. So it goes to reason that if the patient has a normal blood pressure and they have a normal intracranial pressure, that they likely do not need any more invasive intracranial intervention. That's the basic of cerebral perfusion pressure. So just like we simplified the hole at the bottom of the skull, if we simplify this simple fact that if the ICP is low and the mean arterial pressure is normal, you don't have a hypotensive patient, you do not have intracranial hypertension. That's our goal. And the same thing's true in the spinal cord. So spinal cord perfusion pressure is also a function of mean arterial pressure. That's the premise behind MAP management and spinal cord injuries, to increase that perfusion pressure in the spinal cord in the setting of injury and edema. And so how do we do that? Well, it turns out humans, we have been doing this for a long time. So Broca, as you all remember, Broca's area, this was a scientist and a physician in 1879 examining these trephine skulls from the Neolithic era. This Neolithic era was 12,000 years ago. He theorized that ancient peoples, just like Sir Victor Horsley at the time, the father of neurosurgery, were drilling holes in people's head to get out the evil spirits. So inside this skull, the ancient peoples realized that there's 3 things in there. There's brain, there's blood, and there's evil spirits. And really not much has changed in the last 12,000 years. There's evil spirits, and then there's not evil spirits. And so how do we get these evil spirits out of our patients with traumatic brain injuries brain? So this is an external ventricular drain, and many of you have put bolts in, and it all basically is the same. So an external ventricular drain, basically you shove a piece of plastic tubing through a relatively safe portion of the brain into the fluid-filled spaces of the brain. So your landmarks for a bolt are same as your landmarks for an external ventricular drain. And why is that? Like, why do we go right here? Well, this is the coronal suture. Most of you can feel it on your head. Some of us, we can see it on our heads in the mirror. And the coronal suture is this nice landmark. You can feel it. It's this ridge right here. If you all rub your head, you can feel it. And this is a landmark, just like you use landmarks for positioning patients and finding, the gallbladder, the appendix. I mean, there's landmarks that we use. This is our landmark. And basically, this landmark is to keep us away from this area right here. So 4 centimeters behind the coronal suture is the motor strip. That's why we go a centimeter in front of the coronal suture to safely enter the right frontal lobe and enter orthogonally the ventricular system while avoiding the superior sagittal sinus and eloquent motor cortex. That's the basics of a bolt. That's where you want to put your bolt. You want to put it in non-eloquent cortex. You want to put your external ventricular drain through non-eloquent cortex and place it in the ventricular system. So I encourage all of you, especially on your trauma rotation, to come to the operating room with us and do these external ventricular drains. I'm happy for you to do them, as are all my partners, because there are general surgeons and trauma surgeons across the country doing these. So we've talked about the evil spirits. So the evil spirits are induced by multiple things. Trauma, like cerebral edema and brain injury, but also salt problems. So that's like the one electrolyte neurosurgeons actually care about is sodium. Because if you have low sodium, you have too much water, which leads to an ICP problem, which leads to a perfusion problem. And that's the key of critical care, is understanding these big picture concepts. That if you have a patient with a traumatic brain injury who's hyponatremic, that increases the water in the brain, which decreases the pressure, which drives down your perfusion. And that's not good. And so thinking about other, as Dr. Burns was pointing out, what are some other directions? And Dr. Maxwell and I have talked about this. Okay, so we've talked a little bit about pressure. We've talked about ICP. We've talked about treatment options for intracranial pressure by removing CSF. What are some other options? What are some other things that we could potentially do in our patients? And one thing that has generated a lot of discussion recently, especially here at Erlanger, is making a sizable financial investment in cooling our patients. There are some good meta-analyses on hypothermia. So this is the most recent from Critical Care Medicine. And basically what it says is that adults, I think the key here was adults, that were therapeutically hypothermic had an 18% reduction in mortality, which is interesting. So I was kind of thinking about this. I'm like, why is this? And so I was thinking about, what's interesting is the ancients, they were drilling holes in people's head to get the evil spirits out. What's the history behind cold? And I love this guy. He's fascinating, this Wim Hof. If you ever want to have like an extra worldly kind of experience without doing any kind of drugs, because remember, drugs are bad, especially for surgeons, you should listen to Wim Hof talk, because this is the master of cold. And I was thinking about this after Dr. Maxwell and I had talked, and I went back and I listened to some of his podcast, and there's actually a great podcast that just came out this week with this guy. It's the Rich Roll podcast, and he interviews him. And he talks about the importance of cold and the effect on the cerebrovascular system and the cardiovascular system. And he basically theorizes that humans, we are so comfortable. It's 70 degrees and sunny every day here at the Baroness. We keep our houses, above 68 with a nice fire this time of year. And we've been alienated away from cold. And so the yogis in India, they've done these cold therapies. And people for a long time have used cold as a way to treat things. So I think it's interesting that we are taking our patients back into the cold, and it's showing some therapeutic benefits. So to kind of wrap us up about this talk, my pearl number 6 that I did not appreciate in residency was also to enjoy your life. Among all of the hard work, among all the things, we kind of lose focus. And I lost focus of these 4 little things right here for a very long time. My children still think I live in the garage. They never see me get out of bed in the morning. They never see me come home other than through the garage. So it's interesting what surgery does to all of us. They think this is mommy's house and daddy lives in the garage, because that's the only place they see daddy come from. So I encourage you to cherish your family and cherish your life. And then the last thing is as part of this educational paradigm, and another thing that I was listening and reading about is that nothing's free. And we were talking about the cost of these warmers and our own financial cost. And in residency, I encourage all of you to learn and educate yourself about not just your debt and your debt reduction, but to kind of create a plan for your life. And when you're looking at jobs, I've had discussions with quite a few of you of what's the next stage of your life, and to tap into the resources of your mentors, to tap into the resources of other physicians in the community, and then start small. So I enjoyed speaking with you. I hope you have questions, and feel free to grab or call me anytime. Any questions?
Questions for Dr. Miller? Here
Yes.
we go. Dr. Fisher. Give Dr. Fisher them.
Apologize for, excuse me, being hoarse. I've got laryngitis. But when I was a young guy, about 19 to 22 years old, I had a job at the Methodist Hospital in Memphis every summer. And I had the opportunity to do 1,800 operations before I ever went to medical school. And one of the early people that took me under his wing and was really quite a mentor to me was Jody's grandfather, who, by the way, was a Rear Admiral in the Navy. So I used to call him Admiral, and he loved that. He much preferred that to doctor. But I will say one thing that he taught me. I took a 1-month rotation with him when I was a third-year medical student on a neuroscience rotation. One of the things that the Admiral taught me was the rule of threes, and I've never forgotten it. But if you want somebody to remember something, don't ever give them more than 3 things to remember at one time. And if you're giving a talk, I noticed, Jody, you put up 7 things and not 3. What's wrong with you?
I know. Yeah, I failed.
But I've never forgotten that. And in giving talks, if there really are some points that you want to leave with people, or you're writing a paper and you want to leave some points with people, don't ever give them more than 3 things to remember, because they won't remember them. It's the same way with telephone numbers and hospital numbers. I noticed that when Memorial went to when Erlanger went to its new system of CSN numbers, they ran 9 numbers together. Did you notice that? Now, you know how you would remember that a lot better? As if they put a hyphen between 3 numbers, 3 numbers, and 3 numbers. And then you could dictate it so much easier. 303, 404, and then 909. But they run them all together, and then the eyes get all confused, and you can't see them. Just a small point, but something that his grandfather taught me a long time ago. Still alive, by the way. Lives in Florida, I think, right?
Yeah,
I haven't seen him in years. A great man, a wonderful teacher, and a great neurosurgeon in Memphis.
Dr. Greer?
Jody, I had a question for you. Back when the days when I did trauma, which fortunately I don't do that anymore, but we had a patient with monoplegic head injury, yada, yada, yada. CT scan was normal, went to rehab, was worked up, finally found to have a disc rupture, and there was a lawsuit filed. And ever since then, you realize that CTs are not effective in looking at disc herniation, as I understand it.
Right.
A lot of the patients are not candidates for MRIs. So what sort of, how do you deal with, maybe this is something you guys deal with all the time, you know how to deal with it, but
Yeah.
Is that something that worries you about having a disc protrusion or a disc rupture on a patient with a major injury, normal CT scan, really not a candidate for an MRI because of whatever?
Right. Yeah, I think that this gets to the idea of the difficulty in the trauma bay with the medications patients have been administered of getting a good neurological exam. So the most important thing is a tertiary survey. And so when I was an intern on trauma, and I learned this lesson very early, is that my job, but right before discharge, before that patient went to rehab, was to get a thorough neurological exam. And so it's about the vigilance of the provider is the key. And if you have a patient whose neurological exam you cannot explain, I do not think it's defensive medicine. I don't think we're getting a lot of these MRIs for the attorneys. I think we're getting them for the patients. And so that's why there's this voice in all of our heads, and people attribute it to different things. things depending on your religious inclination or depending on your thoughts and feelings about what this voice is. And every single time I have not listened to that voice, it's been a mistake. And so if that voice in your head says, hey man, this just does not make sense. Why is he not moving his left arm? Why is he not moving his legs? Why is he not waking up? I wouldn't overthink it and say, oh, he's just got diffuse axonal injury with a small punctate hemorrhage in the small portion of his right posterior limb of his internal capsule that just also happens to control motor movement to his left arm. Well, I mean, like, what are the chances of that happening, you know? And so sometimes I think all of us are smart people, and we overthink ourselves, where it's much easier for me to get an MRI of the cervical spine, localize the lesion. I don't think we need to do brain, cervical, thoracic, lumbar, and send the patient to the MRI scanner for 4 hours. I think we do need to do good tertiary surveys and follow our patients to make sure that they make the improvement that we'd expect them to. The other point, and this is more to your point about what we do about CT scans, it's really interesting that if you really look at a CT scan, you can always see the disc herniation every single time, if you know it's actually there. So, but you have to go back and you have to window it right between the bone and soft tissue windows. And a lot of times it jumps out. And I've been with some of you in the trauma bay and say, hey man, this guy's got a big disc at 5'6", and you can see it on the CT scan. But it's kind of cheating for me because I know I've seen his exam and my eyes are going right to that point, and I'm windowing it, and I'm playing with it in the trauma bay, or I go to my office and I turn the lights out and then I can see it. So it's about vigilance, it's about attention to detail, it's about trusting your kind of intuition, and that's what makes you a physician. You know, it's all those things kind of wrapped up into a big package.
Yeah, as a follow-up to that, documentation would also be very important. I mean, that exam that you mentioned doing before discharge needs to be clearly documented, because if you then end up in a court of law, if you haven't documented it, it doesn't matter. You know, you can go back and say, I did it, but if you don't document it, then it's a problem for you, at least in the medical legal situation.
Yeah, there was
so a follow-up to that for me would be to you all, because I've not used Epic in the hospital as much as you guys have. How easy or convenient is that to do with the electronic medical record? I asked the question. I don't know.
Yeah, it's very easy.
Very easy.
It's just it's time. You know, it's all time, and we're busy providers. And you know, my greatest weakness is medical documentation. That's the thing I struggle with the most, is documenting, because I don't have, you know, I've got PAs and, you know, and we have residents, but for me to sit down and document my 30 patients in clinic, the 4 surgeries I did yesterday, the 9 people I saw in rounds, it's hard. And so, you know, that attention to detail is really hard for me. And it gets back, Dr. Burns, I mean, you make a great point. So there is an 8-figure settlement against the Children's of Alabama Hospital over a infant with a cervical epidural hematoma that was not recognized on a CT scan. And, you know, the resident overthought himself. He basically said, oh, the kid's moving, it's not a reflex arc, didn't look at the kid's face to see if they're grimacing. So that's the same thing that can happen to us, is that we pinch their legs as hard as we can, and they triple flex, spinal cord reflex arc. Like, oh, great, their spinal cord's fine. And then the attending comes by, examines the patient, and there's no grimace. And they're triple flexing, like, hey guys, we have a major problem, and delayed that child getting to the operating room by a day. The child is a custody of the state of Texas. They published this interesting birth injury. The state of Texas is brilliant. And basically, they needed to figure out a way to pay for this kid's care for their lifetime. So the attorneys for the state of Texas started researching the literature and found this case study. And 10 years later, got 8 figures to pay for this child's care from children. So be careful about what you publish about, especially in people less than the age of 18, because the statute of limitation law is very different, and that gives attorneys a very long time, especially if the child becomes a ward of the state. So there's a pretty well documented literature on that. So it's kind of
Well,
interesting.
for the benefit of the students in particular, I mean, we so frequently start looking at images as the first line of evaluation. Remember to touch the patient, feel the patient, examine the patient, and neurologic exam is really important, and that's been brought out by this point. I think one other point that you made that I would make to the students and the residents as well. You said you went to your office and turned the lights off. That's the way you look at an X-ray. It is my understanding that the Board of Radiology, in the oral board exam of radiology, if the resident or graduate starts to look at images and doesn't turn the light off, it's an immediate failure by the Board of Radiology. The improved ability it gives you to look at an image well that's a simple thing to point out, but you pointed it out without making that all the way. So that's why that happened. Other questions, comments? Yes.
Appreciate your talk. I wanted to just reiterate one of the most important things that you mentioned is the trust no one, expect sabotage. And if you're a medical student in this room, if you can always remember that if you walk into a room and evaluate the patient and pretend as if that patient can rely on no one but you, and you're the only person who can save this person's life, then it kind of allows you to step back and evaluate and pay attention to those small details. And then the other thing that sort of goes along with that is for the residents, my attendings always told me, I'm not training a resident, I'm training my next partner. So if you can evaluate a patient and pay attention to those details as if you were my partner, I think that also affects kind of how you think about the patients that you're taking care of. So I appreciate your talk.
Yeah, I mean, that's a good point. I mean, the people I feel I am most at risk of missing something, the people I end up making myself spend the most time are people I don't like. Like, there are patients we just do not like. And you have to recognize that emotion when you're evaluating some people. And that's normal. And so as med students, and residents, there's a lot of patients you're not going to like. And you want to get out of that room as fast as possible. But those are the people that you miss things on. And so just taking the time to evaluate and just suck it up even though it's painful. And caring for everyone like they are your partner or they're your family member. And I say the same thing to every single patient before I do surgery, is I try to treat all my patients like they're my daughter, sister, wife, mother. And
Ironically, you just reemphasized a point we had here at Grandrounds about 2 weeks ago, is that you are going to have patients you don't like. And that's, I say, double down. Double down on everything you do, which you just reiterated. That's beautiful. Thank you. Dr. Maxwell?
Yeah, great talk, Jody. I want to make one comment about what Dr. Greer said. There may be a slight difference in the resolution back when he was looking at a CAT scan and doing trauma and the resolution of a CAT scan now. I think the technology's come light years in that time frame. But I was wondering if you'd make a few comments about the changes in the management of spinal cord injury and spinal stabilization. Back when I first started doing trauma, people got steroids, they got put on striker beds and delayed surgery, and now we see guys whisking them off to the operating room in the middle of the night to do these complex spine cases to try and decompress the spinal canal. I was wondering if you'd talk about that.
Yeah, so the first thing is steroids, because that's something you can start high-dose methylprednisolone in the trauma bay. And I am very biased on steroids because the person and people that I trained under were so militantly against steroids because they got into this battle in the Journal of Neurosurgery over those methylprednisolone trials. And so I feel that that battle got so dirty that they lost their objectivity. And I have tried to objectively look at that data. But me objectively looking at those 3 methylprednisolone trials led me to believe that the complication rate is higher in terms of pneumonia and infections. The overall morbidity is higher. The clinical improvement, if you look at those studies, is 1 ASIA grade in 1 motor group. So say if you were an ASIA B6, then hopefully you would improve to an ASIA C in C7. So like the effect was so small in terms of clinical improvement, and it was not outweighed by the increased complication rate of putting people on high-dose methylprednisolone. And that's why, as a whole, the recommendation currently, per our guidelines in those trials and the kind of resultant dialogue, is not to give high-dose methylprednisolone. A lot of spine surgeons will do like Decadron. They'll do dexamethasone 10, and then they'll do 4Q6. That's kind of like a vitamin for me. We do that on all of our brain tumor patients. And, I don't think there's increased morbidity with that. Do I think there's a great clinical benefit? No. Now, in terms of your other point of the operative treatment, so for me, back to daughter, sister, wife, mother, son, brother, uncle, father, family member, or me. So if you came in, Dr. Maxwell, great surgeon, with a disc herniation at 5'6", and you were weak and you lost the use of your hands, I would take you myself to the operating room, and I would get the pressure off your spinal cord as fast as possible. If Wyatt, my son, came in with a fracture and he had a piece of bone digging into his spinal cord, I would do the operation myself if I couldn't get a surgeon in there fast enough. So for me, I want whatever is shoving itself into my spinal cord, I want it off. Now, does that mean we should do that every single case in the middle of the night? No, not necessarily, but we should do it within 24 hours. And that's our goal here at Erlanger, is to do and decompress the spinal cord. There's several papers by Failings and Fessler that say early decompression as defined by less than 24 hours. There is some clinical benefit. What's confusing is some of the other studies define early surgery as within the first 7 days. So oftentimes what I think you see here is that we all have busy elective practices, and canceling 30 patients in clinic to do a spine fracture, like I think was the tendency before, is not very palatable. And we get dinged by the Baroness, we are but her loyal subjects, for our cancellation rates. And so would I ever compromise patient care to do an operation in the middle of the night at the risk of getting dinged? No. But would I rather do it at 9 p.m. and just knock it out and be done with it and not have to cancel 32 patients the next day and cancel a whole elective calendar? Yeah, I would. And so I think it's a balance, and if we look at ourselves critically as to why we make some of these decisions, I think you have to look at all the factors. But my most important factor, more than anything else, is that if that were my son or my colleague, what would I do? Would I take the pressure off, or would I let him sit for my next elective day? So I think that's why we're more aggressive here.
How about balancing that in terms of a patient that has other injuries, multi-system trauma too? I mean,
Yeah.
I assume hypotension and things like that.
Oh, that's a great point.
Yeah.
So Dr. Maxwell and I had a patient in the neurotrauma ICU that I was about to take to surgery, and 2 or 3 of the residents were at the bedside, and this kid was white. I mean, he was as white as our coats. And he was hypotensive, and it turns out that he, with his chance fracture, had transected his vena cava, tore his diaphragm, and he would have died on my operating table. Dr. Maxwell saved his life, and then I stabilized his spine 5 days later. So there are circumstances that we've all had that the bones, when they tear each other apart. There's also these very important blood vessels that have a lot of blood in front of those fractures. And so as a surgeon, the sight of blood, or as a neurosurgeon, the sight of blood makes me a little squeamish, especially that degree of blood loss. And if I have a patient exsanguinating from a vena cava injury and I have the patient prone, they'll die on the table. So I always make sure the patient's tidied up before a neurosurgical procedure.
Other questions, comments? Well, Dr. Miller, thank you very much. This has been I think, very excellent presentation, especially our medical students that see them nodding their heads, so they've appreciated it very much. Thank you for being
Hey,
here.
thank you.
Look forward to working with you.
Is Joe Miller? Yeah, he is. Yeah, there used to be two groups. He was. Yeah,